Thank you so much, Devin sir. Thank you for giving me this opportunity. So my talk is on the emerging role of FDCs in glaucoma. The question is there a need for fixed dose combinations? So that's the question. Are they required at all? So I'm going to quickly cover just 10 bullet points, and I hope to convince you that yes, FDCs are the requirement of the hour. Number one, if you look at this slide, it shows that the visual acuity and the stage of the visual field, they worsen even with treatment. Always remember this. So this was a study published by Sharma et al. In the BJO, which showed that 37.5% of the patients, they deteriorated one stage in terms of the visual field over 10 years, and around 9%, they deteriorated 2 stages over 10 years. And it's not just a visual field deterioration, the cumulative blindness also increases with time, even in treated patients. So again, the key word is even in treated patient. So this was published in the American Journal of Ophthalmology by Peters et al., which shows the risk of blindness increasing over time. So in this study, 26.5% became blind in one eye, and 5.5% bilaterally blind at 10 years, 38.1% in one eye, and 13.5% bilateral blindness in 20 years. So if you have a look at this, a large percentage of your patients have the risk of going blind even when they are under your treatment. Now, why is this so? The reason for that is there is a drop in terms of either decibels per year or the VFI. So there is a drop of, let's say, minus 1.5 dB per year, or a VFI loss of greater than 5% per year. In treated eyes, they may 19.4% of patients may fall into the group called fast progressors. So this was a study by Abuslim et al., which showed that close to 20%, they are fast progressors. So even though your patients are being treated, they may still go blind. Also, obviously, you know that the glaucoma quality of life is very important. So the GQLI can be affected as the severity of the glaucoma increases. So we have to constantly re-evaluate our patients, set fresh target IOPs, change the baseline of the visual fields, and add or step up medications if required. So that is where FDCs come in. So gradually you got to kind of re-evaluate your patients and keep changing the treatment. In fact, now the modern thought is that glaucoma is not just an ocular disease. It is a sick eye in a sick body. So this was published by Lee et al. In Ophthalmology 2003. So it said that there is an increased risk of death from any cause and from cardiovascular disease in particular in patients with glaucoma. So you've got to think of it as a holistic point, from a holistic point of view. Number two, monotherapy fails in a large percentage of patients. So this has been published in the EGS guidelines that monotherapy fails to achieve a satisfactory IOP in 40 to 75% of the patients. Even way back, the CIGTS had shown that within 3 to 5 years of treatment, 49% of the patients who start with one drug, they require 2 to 3 drugs. So close to 50% of your patients will require a stepping up of treatment. And a step up, obviously, it favors an FDC. Now, what should be the target pressure? Now, the AGS had already put the value of 18 in our minds, the magic number of 18. But if you look very closely at this study, it showed that in the predictive analysis, eyes with average IOP greater than 17.5, they still had an estimated worsening during the subsequent follow-up. However, those with an IOP less than 14, the worsening was significantly less. So maybe, we need to think whether IOP of 18 or less than 18 is enough. Because even if you have a controlled IOP of 17 to 18, 29% of your patients will still show progression. So probably hitting somewhere around 14 or 15, which will slow down the progression rate to 7%, should be the new target. So 14 is probably the new 18. So this is and the only way you can achieve an IOP as low as 14 is if you use FDCs. A single drug achieving such a low pressure, it's odd. Now, the third point, efficacy of the FDCs versus the components. Now, this may seem something very striking to you all, but this was a review article by Higginbotham, where what they showed was that all the FDCs, a fixed dose combination of dorzolamide timo, fixed dose combination of latanoTimo, brimotimo, and travatimo, all of them, they are more effective than the component meds used separately as monotherapy. So usually our thought is if you give two separate drugs with a target IOP is lower, but that's not the case. So the efficacy wise also, FDCs have an edge. Now this is now an established fact. Even the EGS guidelines kind of state that fixed combination preparations may be preferable to the use of separate instillation of two agents. Also, if you add a prostaglandin to an FDC, you achieve a mean of around 5.6 mmHg further drop. So with just 2 bottles, you can achieve a substantial drop in IOP. Now, this is probably the most important reason why we need FDCs, the compliance and adherence issues in the Indian scenario. So this is a guest editorial by Dr. Praveen Revuri, published in 2023, where he showed that in North India, nearly 50% of the glaucoma patients were non-compliant, and Rajurkar et al. In their study in 2017 had also shown that around 50% are non-compliant. But what is alarming is around 17% are totally non-compliant. They don't use drugs at all. So even though you may be prescribing a number of drops, the patients have the tendency not to use them at all. This study by our very own Prasanna, who's sitting here, the slides are very colorful, just like him. So he also kind of, pointed this fact that around 50% of the patients are non-compliant. So that's an amazing number. So it's not just one study, a number of studies have pointed this fact out. And what is striking is, it's not just in India. Even countries like Taiwan, Hong Kong, Israel, they have a very high rate of non-compliance. So that is really something to think about. Also, this beautiful study by Prasanna, again I'm quoting it. So if you look at this wonderful chart, what it shows is that if you purchase, the number of bottles increases to 3, the compliance drops to 60. And if you're prescribing 4 bottles, be sure that the patients are not going to use them at all. It's 100% non-compliant. Now, this is a very, very interesting study from PGI group, where what they showed was that the drugs per prescription were around 2.18. So already the patients, glaucoma patients who were on AGM, they had more than 2 drugs. Also the number of referred patients, look at the average number of drops. Drugs per prescription is 5. And patients receiving FDCs who are being referred are already 40.8. So there is a huge need for FDCs because of the compliance issues, as well as for these reasons, that already the requirement of drugs has crossed 1 in a majority of the percentage of the patients. This is a study by Claxto et al., which showed that if you increase not just the number of bottles, but the number of doses also, the compliance rate decreases dramatically. So if you have 1 dose, the compliance rate is 79%, whereas if you have 4 doses, it's 51%. So FDCs are associated with an improved adherence, and the EGS prescribes the 2-bottle rule. In fact, the EGS says that adherence may be improved by simplifying the drop regimen. And the best way to simplify it is if you use FDCs. So the prescription of more than 2 bottles of IOP lowering eye drops for simultaneous use should be avoided, as it can lead to non-compliance. Now, these issues are very common. Tolerability. Are FDCs more tolerable? So this particular study by Higginbotham et al. Quoted that the fixed dose combination of brimonidine timolol has more favorable safety and reduced ocular allergy profile compared to monotherapy. So not only the patients will become more compliant, the drugs are more tolerable also. Also, FDCs, as we all know, it will reduce the washout. The lesser number of drops you have, the less is the washout. Now, do the FDCs reduce the cost of therapy? The answer to that is yes. So this is a study from a nationally representative US population. So even in the US, there are people who could not afford meds, skipped meds to save, took less to save, asked for cheaper meds. So it's not just a third world problem, it's a problem everywhere. And if we go across to the spectrum to Russia, so this was a study by Petrov in Russia, he also stated categorically that FDCs are superior to monotherapy in terms of cost effectiveness. So again, in terms of cost effectiveness, it's also good. This is something I can see some eminent cornea specialists in the audience. So ocular surface disorders and drop burdens. So we have a large number of patients who present with these kinds of eyes. So it's hard for the patients to use 2 to 3 bottles plus lubricant. So, FDCs, definitely they reduce the preservative load, but again, is back really that bad? And the answer to that is probably no, unless it is dosed more than 4 to 6 times daily. So you should limit it to not more than 4 to 6 times daily. Also, FDCs definitely make MMT easier. Prasanna is going to talk about it. So now if you have 2 FDCs, you can have a total number of 4 drugs, 3 drops per day. If you add other drugs, so you can give 6 drugs, 7 drops per day, or 6 drugs, 8 drops per day. So it has reduced the number of drops dramatically. So over time, a large number of FDCs have come into being from 1992 to 1998 when Dozotimo came, 2001 Latinotimo, 2005 Brimotimo, 2006 Bimatotimo and Travotimo, 2008 Brinzotimo, 2014 Brimonidine and Brinzolamide, and 2018 Netasudil Latanoprost combination. So what's new? And is it really new? The triple drug combination. So a Dorzo-Brimo-Timo combination study was published way back in 2009. However, these have been pursued. So the same combination, another study was published in 2014. Also Bimato-Brimo-Trimo over time, studies published in 2017, 2020, 2022. And Brinzo-Brimo-Timo, this is unpublished data, it is currently under publication, where it shows a dramatic decrease in intraocular pressure from 25.6 to 15.15. So fixed dose combinations are definitely the need of the hour. So if you want to improve your compliance, reduce your cost effectiveness, and all the other 8 points that are highlighted, you definitely need FDCs. Now, some of the newer FDCs are going to come. But if you look at this Netasudil Latanoprost combination, it kind of mentions here that there are concerns that Netasudil Latanoprost FDC was associated with significantly higher incidence of adverse events. So probably not all FDCs are good. There are some FDCs which are going to be bad. So you have to pick and choose. So, it makes a strong case for my next speaker, Devendra sir. So he's going to talk about Trisopt. So fixed dose combinations are the mainstay of glaucoma management today and tomorrow. Thank you.